Thank you. We haven't completely solved it yet, but I will tell you how we're working to get there. I just wanted to start out by saying when Eric first gave his introductory comments at the beginning, he talked about all the UCSF connections. He probably doesn't remember, but we were house staff together at UCSF, so it closes the loop back to USC, back there. I'd also like to take a couple of minutes and just talk about another topic that Eric spoke about this morning, expanded carrier screening. It's something we've been interested in for a long time. And I don't know if you're all aware, but ACOG just came out with new recommendations last week. And to their credit, they now say that it's acceptable to use expanded carrier screening as a methodology, but in their recommendations, while they do double the number of conditions that they recommend everyone should be screened for, they go from 1 cystic fibrosis to 2. So we've still got some work to do there in terms of getting out the message about expanded carrier screening. So as an aside. What I would like to talk to you today about is the problem, and Eric teed it up also in his talk today, about germline predictive testing for inherited cancer and why it isn't as effective as it should be. And what I'm going to do is give a little background about the problem. Then we'll talk a little bit about our vision and our approach to trying to solve those problems. I'll also talk a little bit about some of the roadblocks that exist, and then some of the solutions that we've come up with to hopefully get around some of those roadblocks. Most of you know this already, but if you look at just BRCA1 and BRCA2, and this question came up earlier, why it's important to look for these mutations. And this is looking at the lifetime risk. And these are highest numbers. It may be somewhat dependent on family history, but you can see that you have between 70 and 85% lifetime risk of breast cancer if you carry one of these mutations. The other question is, most of this data was generated from high-risk couples that were identified because they were high risk. The other question is, if you screen a general population, do they have the same risk for developing cancer? And as it turns out, there's data from Israel suggesting that they do. It may be slightly lower, but they still have extremely high risk for developing cancer. So it's important to identify these mutations. Same thing looking at ovarian cancer and looking at just BRCA1 and BRCA2, you can see that the risk is substantial for the lifetime risk of developing ovarian cancer if you carry these mutations. So again, it's important to screen for these things. The next thing is, and again, it came up, most of the things that I'm going to talk about, at least in the introductory comments, had been asked questions already today, so it makes it easier. But the next question is, you have this increased risk, is there anything you can do with that risk? Are they actionable? And yes, they are. If you look at the association of performing both, either risk-reducing salpingo-oophorectomy or mastectomy for BRCA1 or BRCA2 carriers, it's associated with a much lower risk of ovarian cancer, first diagnosis of breast cancer, all-cause mortality, breast cancer-specific mortality, and ovarian cancer-specific mortality. So yes, they are actionable. There are things you can do. They're not easy choices to make, but there are choices. The same thing is true for Lynch syndrome. This is an interesting study looking at 10 years of surveillance for Lynch syndrome positive patients, and they found no significant increase in mortality compared with mutation negative relatives. So that is very reaffirming data that yes, there is something you can do, and it's important, again, to identify these mutations. Okay. Our vision and our concern is that We feel that people shouldn't be identified with these mutations after they've already been diagnosed with cancer. It has to happen earlier. So what are some of the things we can do? And what are some of the reasons why that isn't happening? Looking at some of the data, and this is a nice study looking at women who were identified with ovarian cancer and then tested. Of the women that were positive for BRCA1 and BRCA2 mutations, 73% of them would not have qualified for testing by regular guidelines. So that's part of the problems. The guidelines are not capturing the percentage of women that we'd like to that are increased risk. Part of the problem is only 5 to 10% of cancers are inherited. So we still don't know the perfect group to look at, but right now guidelines would suggest, and this based on data like this, that we're identifying these patients much too late. And this is a study that Eric also presented earlier this morning in terms of women who were diagnosed with breast cancer and then having BRCA2 and BRCA1 and BRCA2 testing. And he already mentioned that 80% of them wanted testing, but only about 50% of them actually got testing. And what he didn't say was the most common reason, 56% of them, that they didn't get testing is their physician said they didn't need it. So again, we've got some education to do. Another thing I want to talk about, and it's related somewhat to the Angelina Jolie effect, and there was a lot of publicity, as you all know, in the paper. This was one study that came out of the UK. And what this study showed, that following all of the newspaper articles, that the demand for or the interest in genetic testing went up. And one of the interesting things, it went up and stayed up for a long period of time. It wasn't just a blip and came down. At 6 months, it was still much higher. And what that forced the system to recognize is there weren't enough people to deal with this demand for genetic testing, specifically genetic counselors. And that still is a huge issue. Here's one comment from one of the online sources, a woman who was looking for testing in December 2013. The first appointment she could get was in May of 2014. And she called back to change her appointment, and after that she couldn't get one till October, and this was in New York City. So you can imagine how difficult it is in some other areas where there's less availability of genetic counselors to actually see a genetic counselor to talk about testing. So that's a huge roadblock to getting testing. This is data that Janine mentioned when she gave her talk in terms of the new workforce study that came out of NSGC. And as she said, there's about 4,000 genetic counselors now in the US, and they don't expect to reach equilibrium in the need of genetic counselors to 2023 or 2024. And that is assuming, the presumption is, or the assumption is, that there will be no increased need for genetic counselors. That's just at the current need. They won't reach equilibrium till then. So it's going to be even worse than that. Okay, so how do we achieve our vision, and how do we solve some of these problems? Well, the first thing are the NCCN guidelines for testing. And I purposefully put this up at the size that you get when you go online and try to read through the guidelines. Many of the oncologists are familiar with them. They don't need to look them up. But for primary care providers, most of them need to pull this up and decide whether a patient fits these guidelines or not. So they're very complex. And as you can imagine, in the 5 to 7 minutes that a practitioner has to see a patient, that they're not likely to spend the time to go through this. So what do we do? How do we solve for that? Well, here's what we have done to try to help solve that problem. As you know, there's apps for everything. So we have created an app that goes through, and this app is downloaded to the patient's phone. It's not the physician that does it. It's actually the patient that goes through. It goes through their family history, prints out a pedigree for the physician, but then determines what their risk is based on NCCN guidelines. And you actually can change the guidelines to anything you want. Say your health plan has different guidelines, you can modify it for that. But it's set up for NCCN guidelines, so it's very simple. The patient does it by themselves. And what we found is, while sometimes the patient's in the office and may not remember, what kind of cancer Aunt Jenny had, if they go home and take this home with them, they will actually call the family and try to sort all this out. So we find that we get actually much more robust data doing it this way. Another roadblock to getting testing is cost. When I was in practice, one of the questions I hated to get from patients was, how much does the test cost? And, I didn't really feel I could tell them the truth, which was, no one really knows. That doesn't seem too acceptable, but that was the truth. So what we have been trying to do is create a resource so patients can actually find out what the test costs, because we think that's a real roadblock for patients to get tested. And what we do is actually link to each of the insurers. It goes in and will give the patient an estimated cost with insurance. They can click on this and scroll down. It will give them what we are billing the test for, how much of it is applicable to their deductible. It'll give them the CPT code. So all of that information is available for them. And they also can make the decision if they want to, depending if they have a high deductible plan or whatever, depending what that cost is, to choose a self-pay price. Now, it wasn't just as easy as connecting with the insurers. First, we thought that that's all we needed to do. But as it turns out, a lot of the information you actually get, even electronically linking with the insurers, isn't that correct. So what we had to do was actually look at payment histories from all the insurers and develop algorithms for each one of them to make this more accurate. And right now, we're at a very high degree of accuracy. So we feel that patients are really getting an accurate indication of what it's going to cost before they have the test done. Okay, let's talk about the problem of lack of genetic counselors. And the way we have tackled this is not to try to take over the role of genetic counselors. We have many genetic counselors working for us. We feel they're extremely important. But we've tried to look at the tasks that are repetitive and don't necessarily need individual genetic counseling. The first thing is just pretest education. When a genetic counselor meets with a patient, the first 10-15 minutes is generally the same, just background explanation of the test, what the test results may mean. So what we've done is put that on the web so patients can log on and actually go through that themselves. Then, after the results come back, what we've tried to do is also provide information to the patient. And what we do is provide first a general set of videos that they can click on and look at about their results. Most of them are negative, of course, what those results mean. And it explains that just because, say, for cancer they have a negative result doesn't mean they're not at increased risk. It just means they don't carry the mutation. So we go through all that. And that, again, takes a lot of the burden off what the genetic counselor specifically has to do for a patient. The other thing, though, after they finish looking at this, is they can click on a button, they can speak with a genetic counselor immediately. Within about 5 to 7 minutes, a genetic counselor will pick up and will go through individually what their test means, what their test results are. Patients are very happy with this type of genetic counseling. Satisfaction scores are quite high. Patients can call back and get follow-up genetic counseling information if they need it. The other thing they can do, some patients would rather schedule an appointment later when their partner's around or at a more convenient time, so they can schedule an appointment to do it. So they do that all from that initial screen online. So those are some of our solutions. Again, they won't solve all of the problems in terms of extending germline testing, but we think we've created some that will make it much more accessible, and our hope is that the majority of patients who find out they're mutation positive won't do it after finding that they've already had cancer. Thank you.